Welcome to Lexcura Clinical Insights, the podcast where clinical evidence, healthcare standards, and litigation strategy come together. I'm Michelle Carroll, founder and chief clinical strategist of Lexcura Summit. Emergency departments are fast-moving, high-pressure environments, and triage decisions can determine how quickly a patient receives critical evaluation and treatment. The Emergency Severity Index assigns patients a level from 1 through 5 based on acuity, immediate risk, and anticipated resource needs. When a patient is under-triaged, the problem is not simply the assigned number. It is the delay that follows, and what happens clinically while the patient waits. In this episode, I will explain how to read the triage note, evaluate the ESI assignment, identify the warning signs that should have prompted a higher level of urgency, and connect the under-triage decision to deterioration, delayed treatment, and resulting harm. Did you know that in the US, emergency departments see over 130 million visits a year, and yet a significant percentage of patients are miscategorized during triage? That's what we're diving into today. How triage systems, EMTALA, and time to treatment failures impact emergency care.
Wow, that's a staggering number. And it really highlights just how critical it is to get triage right. I mean, when you think about it, the emergency department is often the first line of defense in healthcare.
Exactly. And the Emergency Severity Index, or ESI, is supposed to be the tool that helps prioritize care. It's a 5-level system designed to sort patients based on how severe their condition is and how many resources they're likely to need.
Right. Level 1 is for the most critical cases, patients who need immediate, life-saving intervention. These are the ones where every second counts, like someone in cardiac arrest or a patient who's completely unresponsive.
Then there's Level 2, which is still high priority, but not quite as urgent as Level 1. These patients are at high risk of deterioration or experiencing severe pain or distress.
And levels 3, 4, and 5 are for less urgent cases, with level 3 being a bit of a grey area. These patients might not be in immediate danger, but they often require a lot of resources, like lab tests, imaging, or consultations.
That's where things can get tricky. The ESI is a great tool, but it's not foolproof. It relies heavily on the judgment of the triage nurse, and that's where subjectivity comes into play.
And that's how under-triage happens, right? When a patient is assigned a lower ESI level than they actually need.
Exactly. And under-triage can have serious consequences. For example, if a patient who should be a level 2 is triaged as a level 3, they might not get the care they need in time.
It's such a delicate balance. Triage nurses are essentially the gatekeepers of the emergency department, and they're working under intense pressure with limited information.
And then you add EMTALA into the mix. That's the Emergency Medical Treatment and Labour Act, which requires hospitals to provide emergency care to anyone who needs it, regardless of their ability to pay.
EMTALA is such an important law, but it does add another layer of complexity. Because hospitals can't turn anyone away, emergency departments can get overwhelmed, especially in areas where people rely on the ER for primary care.
And when emergency departments are overcrowded, that's when time to treatment failures start to happen. Even patients with high ESI levels can face delays.
It's like a chain reaction. If the waiting room is packed and there aren't enough staff or resources, the whole system slows down.
And the consequences of those delays can be devastating. Studies have shown that longer wait times are associated with worse outcomes, particularly for conditions like heart attacks, strokes, and sepsis.
Let's talk about sepsis for a moment. This is one of those conditions where every minute counts. Delays in recognizing and treating sepsis can lead to organ failure and even death.
Absolutely. And yet sepsis can be tricky to spot in its early stages. It's not always obvious, especially if the patient isn't presenting with classic symptoms.
Which is why triage is so critical. The ESI system is supposed to help flag high-risk patients like those with sepsis. But if the triage nurse misses the signs, or if the department is too overwhelmed to act quickly, the system breaks down.
And it's not just sepsis. Think about strokes. There's a narrow window of time to administer treatments, like TPA, which can dissolve clots and restore blood flow to the brain.
Right. And if a stroke patient is under-triaged or delayed because the ER is swamped, they might miss that window.
It's heartbreaking to think about. These are preventable outcomes, but they happen all the time.
So what's the solution? How do we fix these systemic issues?
That's the big question, isn't it? There's no single answer, but there are a few things that could help.
For starters, better training for triage nurses. The more skilled and experienced they are, the less likely they are to make errors.
Agreed. And then there's technology. Some hospitals are using AI and machine learning to assist with triage. These tools can analyze data and flag high-risk patients, potentially catching things that a human might miss.
That's promising, but technology isn't a magic bullet. It's a tool, just like the ESI, and it needs to be used correctly.
True. And then there's the issue of staffing. Many emergency departments are understaffed, which makes it harder to provide timely care.
Staffing is such a big piece of the puzzle. More nurses, more doctors, more support staff. It all makes a difference.
And let's not forget policy changes. We need to address the root causes of overcrowding, like the lack of access to primary care and mental health services.
Absolutely. If people had better access to care outside of the ER, they might not end up there in the first place.
It's a complex issue, and there's no one-size-fits-all solution. But the stakes are too high to ignore.
Every patient deserves timely, high-quality care, no matter who they are or where they come from.
And that's what it all comes down to, making sure the system works for everyone.
Well said.
Thanks. And thank you for this conversation. It's such an important topic.
It really is. And hopefully, by shining a light on these issues, we can help push for change.
Here's hoping.
All right. That's it for today.
Thanks for listening, and we'll see you next time. Thank you for listening to Lex Cura Clinical Insights. An under-triage case must be built from the complete emergency department timeline. The analysis should compare the presenting complaint, vital signs, pain score, mental status, risk factors, nursing observations, ESI level, reassessments, time to provider, diagnostic testing, treatment, and the patient's subsequent deterioration. The key question is whether the patient's condition at arrival supported the assigned triage level, or whether the available findings required more urgent evaluation and closer monitoring. When the record shows that serious warning signs were present, the patient was assigned a lower level of urgency, and treatment was delayed while the condition worsened. The triage decision may become central to both breach and causation. That is how the waiting period becomes part of the clinical evidence, rather than simply an administrative delay. For more clinical intelligence, litigation analysis, and practical guidance, visit LexCura Summit at lexcurasummit.com. I'm Michelle Carroll. Thank you for joining me, and I'll see you in the next episode of LexCura Clinical Insights.